Thank you for joining us for the second half of the newly diagnosed session. If you didn't get a chance to join the first half, be sure to check out the recording when it's available for replay today or tomorrow. In this second half of the session, Dr. Mary Schroth and Dr. Rob Graham will be sharing helpful information about treatments, trials, and care for pre-symptomatic families. I would now like to introduce Dr. Mary Schroth, Chief Medical Officer at Care SMA. Mary?
Thank you, Sarah. Hello, everyone. I'm Dr. Mary Schroth, Chief Medical Officer at Care SMA, as Sarah introduced me. I'm so pleased that you're able to join us today for this session as part of the newly diagnosed program. I will spend the next few minutes discussing SMA and clinical care related to SMA. At first, I want to share a little bit about me. Before joining Care SMA 3.5 years ago, I provided care to people with SMA as a pediatric pulmonologist in Wisconsin. In my role at Care SMA, I can impact on a much larger scale, reaching not only patients, but also healthcare providers as we continue to learn and share what we know about SMA. Next slide. As Kenneth mentioned earlier, support, research, and care drive the SMA community. This conference is an opportunity to bring the entire SMA community together. I will focus on SMA care and healthcare specifically. Thinking about your child's health and making decisions that impact the health of your child with SMA occurs every day. Receiving a medication or medications that directly treat the genetic cause of SMA requires care to optimize the outcomes of these treatments. Next slide. So I recognize that everyone may know this information, but just to have everyone on a similar page, I just want to briefly talk about SMA as a disease. So the underlying cause of SMA is due to a gene mutation, and the result of that mutation is that there is much less survival motor neuron or SMN protein that is being produced in the body. So one way to think about SMA is that it's an SMN protein deficiency. And this deficiency results in disease of the motor neuron. So it's a nerve disease. But those motor neurons send messages from the spinal cord to the muscles, and that's how we get the weakness that's associated with SMA. SMA is a degenerative disease. People report fatigue as well as the muscle weakness, and there are multiple parts of the body involved. We all know about the muscle weakness, the musculoskeletal involvement, but it also impacts the muscles for breathing, muscles for swallowing, and that impacts GI and nutrition, and also bone health can be an issue for people with SMA. Next slide. So SMA is an autosomal recessive disease. And what that means is that people who are carriers do not have SMA, but they have one gene for SMA and a normal gene. And when those two people who are SMA carriers have a child, there's a 25% chance with each pregnancy that the child will have SMA. There's also a 25% chance that the child will have both will have normal genes. And then a 50% chance that the child would be a carrier for SMA. We currently know that the carrier rate is 1 in 50, and the incidence estimate is approximately 1 in 11,000 live births. As newborn screening is rolling out and being implemented across the U.S., we're learning more information about the actual incidence, and as we gather that information, we'll share that out. SMA is diagnosed by gene mutation testing. More than 95% of individuals with SMA are identified by doing the standard gene mutation testing. The SMA gene is on chromosome 5, and it's on the Q area of the gene or the chromosome. And in SMA, both genes for SMA have the deletion of the SMN1 gene. The remaining 5% of individuals have a point mutation, and it can be picked up, but it requires additional testing. It's actually gene sequence analysis. Historically, SMA is the most common lethal genetic disease of children under 2 years of age. And with the treatments that are now available, this is changing, and it's changing rapidly. Next slide. So this is a slide of normal SMA genes. So on the right, with the circle is the SMN1 gene, and this is the primary gene that determines whether an individual has SMA. This SMN1 gene produces 100% functional SMN protein. And people who have at least one functioning SMN1 gene do not have signs of SMA. Next slide. The backup gene, SMN2, produces some functional protein, only 10%, and 90% is non-functional. So for someone with SMA, their SMN1 gene is not working at all. So there's no protein being produced by that gene. And they're relying on the SMN2 gene to produce SMN protein. And for each SMN2 gene that an individual has, and we think of SMN2 as the backup gene because it does produce some SMN, but just not as much or as efficiently as the SMN1 gene. And it produces about 10% of functional protein. So with this information, what we know about SMA is that the more copies of SMN2 that you have, the higher level of function. But there are exceptions to this. It's not perfect. Next slide. So knowing the genetic cause of SMA has led to this incredible opportunity to identify disease-modifying treatments. What researchers in this area have discovered was that if they could enhance production of that SMN protein, that increases the SMN protein levels and improves outcomes for individuals with SMA. There's two categories, general categories of SMA gene modifying treatments. One replaces the function of the SMN1 gene, and that is called Zolgensma. It was approved just 2 years ago. And another mechanism is altering the splicing of the SMN2 backup gene so that more full-length protein is produced. And the first treatment was Spinal, and that was approved in 2016. And Registry was approved in August of last year. So we have 3 different treatments that are FDA approved for SMA, and the clinical trials have demonstrated that these treatments all significantly impact outcomes of this disease. Next slide. Because of the dramatic changes in SMA outcomes due to these treatments, care is more important than ever because we want to optimize the impact of these treatments. We have several years' experience using these treatments. They have been closely studied in clinical trials under ideal situations with a patient population that fit very specific criteria. And with that, we need to learn more about these. And with your partnership and as a community, we are continuing to learn more about these outcomes and how to best use these treatments, especially in what we refer to as real-world evidence. So people with SMA who didn't fit into a clinical trial for a variety of reasons, we're learning about how those individuals are responding to these treatments. So as part of that, we recommend regular follow-up clinic visits with your SMA care team. That care team will monitor for symptoms of SMA. They'll monitor for side effects of the treatments. None of these treatments are perfect. None of these treatments are a cure for SMA. They're treatments. They make the disease better, but they don't relieve all of the symptoms or the fact that people having SMA. And they also are, during these clinic visits, they will also evaluate ways to optimize the treatment outcomes, things such as physical therapy, equipment, different things that can be applied depending on the needs of the individual. Next slide. This slide just shows you how important it is to have a SMA care team. And not one person can provide all the care. It really takes a village to provide care for individuals with SMA. This care team should include multiple specialists and healthcare providers depending on the needs of your child. At the center of care is the individual with SMA, surrounded by family, and the next layer is the clinic coordinator who helps with navigation through the healthcare system and with the many specialists determined by the team. Not everyone needs every one of these specialists, but they generally, people need more than one individual from the healthcare team to guide toward optimal results. Next slide. Some of the areas that are critically important to SMA health are the following. Physical and occupational therapy. And the goals of physical and occupational therapy are to optimize function, optimize independence, and mitigate the impact and optimize the impact of these new treatments. You're receiving these treatments, we want to see the best possible outcomes, the highest level of function that is possible. Nutrition is another important area. Growing and gaining weight is key to optimizing motor function and strength. The body needs energy in order to continue development and to continue to optimize these outcomes. Monitoring swallow is a big part of the nutritional assessment. Breathing, which we know historically has been the major cause of death for people with SMA historically, requires close monitoring. There are a lot of tools that we can use for breathing support, and that includes when there's difficulty coughing or clearing secretions, we have equipment, or if someone needs breathing support during sleep. One of the things to know about having SMA is that viral respiratory infections exacerbate motor weakness. So even if you're, and this is true for people without SMA, is that whenever you get a viral respiratory infection or a viral illness, it makes you weaker for a period of time. And then as you recover, you regain your strength. There's a beautiful study done 30 years ago that looked at this and demonstrated that everyone who gets a viral illness becomes weaker for a period of time. And the degree of weakness is the variable. So it is possible that someone with SMA would do great day-to-day, but with an illness, they may have a little bit more difficulty with swallowing and with breathing, and they may be able to do less. So it's just something to keep in mind. Next slide. There we go. Thank you. So I wanted to point out to you that these are the most recent documents for the SMA standard of care. These were last revised in 2018, and they're 2 documents, and these are available on our website. I want to let you know that Cure SMA is leading an effort to update these care guidelines with healthcare providers. We've established multiple groups, and we'll be looking at the different areas of care over the next 3 years and updating. This year, we're committed to updating information about diagnosis, information about treatment considerations, and also looking at mental health in SMA and what are best practices and what can healthcare providers do to help people with SMA in an optimal way. And our plan is to have these topic areas published end of this year, early next year, and then to distribute that information throughout the U.S. and globally so that any healthcare provider who's caring for an individual with SMA has access to that knowledge and can utilize it in their clinical practice. Next slide. So I'm going to shift gears here a little bit, but just as we're talking about, how do we learn about how people are responding to these treatments? And this is one of the efforts that Cure SMA has to learn more about what we're calling real-world evidence, or what happens after these drugs are approved. And all people with SMA with a variety of levels of weakness and strength and considerations are able to utilize the medication. So Cure SMA has partnered with neuromuscular clinics across the country. We currently have 19 centers. Our goal is to get to 50 centers. And when these centers see patients, if you're going to a center, and there are centers across the country that provide excellent care that may not be part of the care center network. We're continuing to grow this network. So I just want to assure you that if you are receiving great care now, don't switch. Stick with the team that knows you, that's getting to know you, and continue to work with them. Our goal is to have more and more centers join us over the next several years. When these centers see patients, they ask for consent to send information that's in the electronic medical record electronically to our clinical data registry. So data is sent to us from the medical record. We're trying to be efficient about that data collection. And then we deliver that information back, make it available to the care center that supplied it, and then we also share it out with the SMA community so that we all can learn. And we utilize this information to advocate to payers about access so that these medications could be more readily available to individuals with SMA because we've demonstrated the impact on the disease. We also use it to develop new therapies. As I said before, we're not done identifying new treatments for SMA. There's much work to be done, and collecting this data provides us with opportunity to learn more about where those gaps may be to develop more treatments. Next slide. So one of the ways that you can help us, so the last slide just showed you data that's being collected by healthcare providers and being shared with us. There's another way to collect data, and that's getting information directly from you, the families who are involved in SMA, who have someone that they are caring for with SMA, and we invite you to participate. We have 3 registries currently. The first one is the Newborn Screening Registry. And this is available for children diagnosed through newborn screening or who were identified prenatally. I ask that you go in, complete approximately 20-25 questions about the experience of newborn screening, information about your child, SMA2 copy numbers, what treatments they're on, just to help us, again, gather more information about the real-world experience. We also want to learn about the impact of newborn screening on care of SMA. The second survey is for all newly diagnosed individuals. So if you complete the newborn screening registry, you can also do the newly diagnosed survey because it's open to anyone who's been diagnosed in the last year. And then our third survey is what we call the community survey, and this is open to everyone in the SMA community and is available right now. Online, if you go to our website, it pops up inviting you to participate. And a new survey is put out every year currently and made available to the community. We send out notifications for when people can participate. So again, I invite you to help us learn more about what is happening related to SMA, your experiences with SMA in the community. Next slide. The next 2 slides are just sharing information that we have collected regarding from the Newborn Screening Registry. So we currently have 39 infants that are in our registry, and those infants are represented by 47% have 2 copies of SMN2, 6% have 1 copy, 32% have 3 copies of that SMN2 backup gene, and 16% have 4 or more copies of the SMN2 backup gene. 2 families reported that their child had symptoms at birth, and those are all fascinating information, and these are some of the questions that are asked. Next slide. This slide shows you median age of diagnosis. So these were infants that were, again, identified through newborn screening. And newborn screening is exactly that. It's a screen. And then additional blood is required to do the gene testing and confirm the diagnosis. And this is the first graph on your left is demonstrating the median age at which diagnosis was confirmed. And for the entire group, which is the first column, it was 6 days, which is great and pretty typical for newborn screen turnaround time after obtaining confirmatory testing. The 1 copy infants, it was 10 days, and that was 3 babies. 2 copies, it was 7 days. 3 copies, 6 days, and 4 copies, 6 days. The graph on your right shares median days from diagnosis to treatment. And the median overall, the entire group is 22 days. Ideally, our goal is to decrease this time from diagnosis confirmation to treatment to 14 days. So again, I ask for your help in collecting this information so that we may see over time implementation of newborn screening and training the healthcare providers and responding to the positive newborn screens efficiently. And we want to see this change over time. Next slide. Thank you all so much for, again, your attention and listening to this presentation. And now I have the pleasure of introducing Dr. Robert Graham. He is a senior associate in the Division of Critical Care Medicine, Department of Anesthesia, Critical Care and Pain Medicine at Boston Children's Hospital. He's also affiliated with Harvard University. Thank you, Dr. Graham.
Mary, thank you. And I want to start by also thanking all the staff and volunteers at Cure SMA. Just some background. So I've jokingly said in the past that I'm the guy you never want to see. I'm a pediatric intensive care provider. And unfortunately in the past, I had met many a new SMA family as they presented to the intensive care unit with their infant or toddler with acute pneumonias and other problems. I am the guy you'd want to see because I also run our home ventilator program and work in a multidisciplinary SMA clinic to help families make decisions and navigate the challenges of their needs and projected needs and choices. So it's in that role that I'm really sort of coming to you as an advocate and otherwise. So what I'm hoping to do today is help you understand what treatments and trials are all about. And I also want to applaud you for coming. I mean, you're here as a pre-symptomatic family or friend or affected individual, which is amazing. But the fact that you're here means that you share with us the need to sort of continue, as Mary was suggesting, to optimize our understanding and care for people with SMA. Next slide. So I don't really have any conflicts of interest other than to say that, like everyone else involved in Cure SMA and in the SMA community, my conflict is that I want to help all of you and help us as a community sort of move things forward and recognize that we don't yet have a cure. We have treatments. And so that's part of what we're trying to achieve here today is to sort of, and throughout this conference and moving forward is to sort of improve all of these things. I have been involved in a number of research efforts, as you can see listed here. I don't have any commercial sponsorship. Next slide. So part of the goal today is to address, honestly, the frustration that you probably have. And even though you're here as a pre-symptomatic family or friend or individual, that doesn't mean that you don't have questions and frustrations and fears and otherwise. This slide, actually, Kenneth, who you've met previously, and Tom Crawford, one of our senior neurology colleagues, we've all used this slide in various forms. And it doesn't have numbers attached to it or otherwise, but it sort of reflects the history of where we've come as a community and where families and individuals with SMA have sort of had ups and downs over literally decades. As research has advanced and the hype and excitement about new treatments or possible treatments and research trials went up and down, and then things didn't work out, and sort of that frustration grew. But what was always there was the hope that we would get to a cure and get to treatments and things like that. And amazingly, and as Mary showed, we have 3 treatments in the last 5 years that have been approved, which is honestly, it's almost inconceivable for many of us to be at this point. But what I think that shows is there's still a lot of uncertainty, which is one of the reasons I want to talk to you a little bit about research in general today and how do you think about that. But it doesn't necessarily attenuate some of the frustrations and fears that you've got. As Mary pointed out, even with newborn screening, there's still a little lag before treatments are implemented. An average of 22 days, which for some of you who may actually still be waiting to get a treatment, even though you're pre-symptomatic, there's frustration there. There's anger that, or questions, why did this happen to my family or me in particular? So it's not to say that everything is fixed, and that's sort of how we want you to sort of think about stuff as you engage with the community, and truly you'll You'll see families who are at all different stages and individuals throughout the course of this meeting, and hopefully as we move to the future and get back convening in person for next year's conference. Next slide. So what I'm hoping to do in the course of this session, and it's abbreviated, and honestly, I'd also encourage you to reach back to Cure SMA, your home providers, or a care center for more discussion and thought about this, is I want to talk about some of the ethical and emotional and pragmatic issues around medical research and actually treatments. I'm going to talk about the types and phases of research briefly, and then think about goals and expectations of the different stakeholders. And yes, you as the affected individual or family are our primary focus, but recognize that there are other stakeholders in this that have different objectives and goals, and they may not always align with what yours are. And then also, as you're going through this session today, think about and look through the sort of the agenda for the rest of the meeting and think about areas that you want to do. It's a lot, especially if this is your first meeting as a newly diagnosed family. There's a lot to absorb. And so you may want to come back to it at later dates. Next slide. So as I said, and Mary highlighted, we have 3 treatments. And there's a lot more research being done, but it's such a different landscape than it was 5 years ago, and 10 years ago, a different world. And I think this is one of the things that we're charged with helping you navigate. As I said, the bird in the hand is worth 2 in the bush. You can use other sort of analogies. What treatment is best for me, or is the treatment that I've received, do I need something more? And how do I do that? And how do I weigh the risk benefits of those? Next slide. I think in general, and I don't know if there's anyone watching this this session from Montana, but I remember driving through there as I moved to the East Coast years and years ago. This was the speed limit. By day, it was reasonable and prudent, and how you interpreted that was up to the individual. I think the same applies to families. You're all going to have a different perspective on that. It's important to sort of think about that. And if you're a 2-parent family, each parent doesn't necessarily have to agree, or they may not agree, but it's helpful to sort of think this through and talk it out and say, okay, what is reasonable and what is prudent, and how do you make sure that everyone's sort of on the same page? Next slide. So research is not one thing. I think traditionally we think of research as being, certainly for something like SMA, okay, what's a drug that's going to fix my child? Or if you're a young adult and it's like, what's a drug that's going to fix me? But in fact, actually, research encompasses a lot of different things. Yes, there are clinical trials, which is what most of us think about. As I said, that's how we got to nusinersen. That's how we got to Zolgensma. That's how we got to risdiplam. These were drugs that went through clinical trials and were shown to be effective and are now on the market and they're accessible to you. But there are also other areas of research. There's prevention. There's diagnostics, as Mary said, we're even updating the guidelines on that. There are new diagnostics. There's screening. The newborn screening was part of research, and applaud those clinical providers that sort of pushed for that. That's really helped us, especially for you as a pre-symptomatic group. That's probably how you were picked up, and that was all a product of research showing that this is effective at picking up new SMA infants and toddlers, and that we can make a difference. There's research around quality of life, supportive care. Like, what is it, as Mary said, help complement and supplement the treatments, the drugs that you may have pursued? What are the other aspects of care that we can help improve? Genetic studies, the epidemiology, and natural history. Really learning about what's happened with SMA historically and what's happening going forward with the different treatments. Because as I said, there's a lot of unknowns still, even with treatments. Why does each child respond a little differently? Why does one child with SMN2 copies look different than another child with it? And how are these drugs interacting, if at all possible? So, we have a lot to learn, and that's why we would encourage you to think about this and understand what research prospects there are. Next slide. So it is helpful to recommend or realize that there are different paradigms. There's medical therapy and medical research, and they are very different paradigms. You may receive medical therapy and have medical research through the same provider. In our own clinic, we have research protocols, and we have people receiving SMA targeted treatments as part of medical therapy. But they're very different, and it's helpful to understand that as you're working with your team in terms of what category are you falling under. If it's medical therapy, it's really meant to be for you. This is an approved therapy, an approved drug, and it can be adjusted. Although with the current treatments, that's not really like a blood pressure medication where you can go up and down. Rather, it is as it's been approved by the FDA. But the objective is to help you improve your symptoms, improve the condition, limit the nerve loss from SMA in particular. Medical research is not about you, but it's about how you respond within a group. How if we apply this treatment, and honestly, I think we owe a lot to the families that chose to participate in the research for Spinraza, for Zolgensma, for Risdiplam, and the ongoing trials. That there was the prospect of benefit, and we'll talk about that. But it was really not about them, but rather how the entire group results were. There's strict adherence to the protocols. You can't change things. So if you think you're doing well, that doesn't mean you can get more. If you don't think you're doing well, you can't necessarily get more or decrease. There's strict adherence to it. And again, it's all about the numbers. It's less about you and how what your thoughts are about that trial and that treatment. Next slide. It's helpful, albeit a bit cynical. I think this quote, an investigational drug is a substance that when given to a rat or a research subject produces a paper. It's a bit of a cynical view, but I think it is helpful to sort of realize that again, there are different stakeholders, and investigators, basic science, clinical researchers, and otherwise, they want to move things forward to help the science, to help the community, but it also helps them as individuals. And unfortunately, if they find something that doesn't necessarily work, it may not get published. And that's unfortunately a sort of a problem with our system and how it's done. So we're still learning about stuff. And what we may not recognize is that there are things that we learn that are negative in these trials that may or may not be propagated. And so it's helpful for you to continue to work with providers and work with SMA, Cure SMA, to express what it is that you're experiencing and you or your child, and how things are working for you, because we have a lot to learn. Next slide. So research, as I said, it is helpful to understand the FDA phases of research. And the 4 phases that I've outlined here on the slide actually reflect what's happening or happened after it's been through basic science in the lab, in animals. And these are the first steps in how do we get it to you, the family or patient. So phase 1, and this is really all about safety. This is the first time when a drug will be trialed in a human being, adult, child, or otherwise. And oftentimes they will use them in adults before they do children, although SMA is an exception to that, because you need to start when the condition is starting or has already taken process. So this is all about safety, and it really isn't about does the drug work. It's more about does it hurt you. And then phase 2 is efficacy. Does it work? And design. And for those who went through, if you talk to families who were part of the nusinersen Spinraza trials, that was a placebo control. So there were some families whose children didn't get the drug, that they were getting fake lumbar punctures, as it were, to get administration of it, and they were the control group. It was like, I'm going to compare, children who get it to those who don't, and follow them and see if there's a big difference. There were lots of ethical concerns around that, but that was sort of the standard to which the investigators were held. Zolgensma and Risdiplam and the other ones going forward have had some advantages learning from that, and have had a different standard, but it's helpful to know about that as you're going into a trial. Am I going to get it? What are the risks? How safe was phase 1? Phase 3 is a dose variation. Are higher doses better than lower doses? Are the side effects different in in each of the groups? And sometimes phase 2 and 3 can be merged, actually. So it's helpful to sort of remember that. And happily, we are at a phase 4 in several of these drugs now. And these are after FDA approval. So when you can get them, and presumably when you've gotten them now. And it's when we compare drug to drug, we look at long-term risks and benefits and effectiveness. But it is helpful to know that things come up. And if you look historically, there are drugs and other conditions that have been pulled off the market. For those old enough to remember, there was a drug called Vioxx, which was for rheumatoid arthritis. It's sort of, think of it as, a super ibuprofen or Motrin, sort of in the same family there. After hundreds of thousands of people had this, there were actually probably more like millions, there were higher incidences of stroke. And it was taken off the market, and we can't use it anymore. There's a drug called Felbutol or Felbamate. It's a seizure drug, which again, many children and adults had been on, and years after it had been approved, there were noted to be issues with it. And so it's helpful to remain engaged so that we can learn about longer term side effects. Next slide. Our first, first do no harm, Hippocrates. And I think that's part of it. And as we sort of think about, as you're working with your team about treatments and trials, that should be the goal of the clinician, the investigator, and you. We want to make sure that everything goes as well as possible that we can control. Next slide. And aligning that expectation and understanding of what a treatment or a trial is, there are some misconceptions that we talk about. There's the therapeutic misconception, there's a therapeutic misestimation, and then there's therapeutic optimism. And all of this reflects our desire to have everything go as well as possible. And I think it's helpful to sort of think about each of these, whether you're the patient or the parent or a friend or family, is that you have to understand what the research or treatment is supposed to do. There are things that are still under trial that don't affect the SMN gene itself or the SMN2 gene, but are targeting muscle, or they're doing other things to the body. And maybe that's helpful, but it may not necessarily make you stronger, but may affect other symptoms. There's therapeutic misestimation. And this was really a big challenge, as I said, in the first trials of nusinersen, where there's a placebo and a control. So some kids would get it and some kids wouldn't. And there was a misestimation, or even, as I said, a misconception that, yes, my child will get it and they will benefit from it. But in fact, actually, that wasn't necessarily true. I mean, when you look at the odds and otherwise, you want to sort of be aligned with that. And then there's the optimism. And I think all of us do this. I mean, we are hopeful that whatever we're going to take is going to help us and not harm us, or it's going to help us more than whatever the prior treatment would be. And so it's helpful to sort of be realistic, although continuing to be hopeful. Next slide. Lots of pragmatics and considerations when you're thinking about treatments. And this is something, again, to come back to your teams with, and, who's eligible? Why would they be excluded or included? And this can be challenging as you're looking at, oh, we know a family down the street with SMA and they can be in the trial, but why can't we? Why, we talk about washout. Why do I have to stop a therapy? If it's a therapy that's, taken daily or every 4 months as the things that we think about now, why would stop starting another, things to think about and ask. There's confidentiality, which is the challenge in our community. It's a small community and everyone knows everybody else's business, which can be good, but it can also be bad as we, try and maintain a degree of privacy. There's lots of commitments to these trials. If you're going forward, there's incentives, there's disincentives in terms of logistics. And I think it's really helpful to sort of go through all of these things. And please feel free to refer back to these slides if you're considering it to ask questions. But really, your team should be very transparent about what are projected risks, what are projected side effects, If this is an industry-sponsored trial, there may be contingencies and reparations if something goes wrong. So it's helpful to understand all of that up front. Next slide. And then other things to consider. There are definitely benefits to being in trials, separate from the treatment itself. You will have access to things that others may not, whether that's the drug itself, but you'll be engaged with a team of clinicians and researchers, presumably, who are going to be watching you and scrutinizing things even more closely. And then really there's the altruistic aspect of it, that you're helping others, you're helping the general community. And I think actually that doesn't just apply to the drug trials. As I said, this is part about epidemiology and responding to the surveys and otherwise, is that we are helping each other as a community with these types of things. And then the possible risks. As I said, there are things to consider when you're engaging, and there's the reference at the bottom pertains to sort of cancer research, but I think you can extrapolate it and apply it to everything that you're going through as a family with SMA. How complicated will this make my life, and will it benefit it substantially, in terms of the stress on you? Like if I have to come in every 2 weeks and fly or go through snowstorms or otherwise to get to the site where the treatment is, does that cause me to miss work? Does it change my finances? Does it put it at other risks? What does this do to the rest of my family and other children that may be affected, siblings and otherwise? Next slide. So as I said here, if it only were that simple, and I think it's actually getting more complicated as we have pre-symptomatic diagnosis, which is phenomenal, that the overlap in types and the blurring of what is the traditional SMA type 1, 2, 3, which is what you'll all hear about, is that relevant anymore? And how does that, how do we consider enrolling people in trials, and how do we target treatments and therapies? And, some would say, the enemy of good is perfect. If I'm doing okay, do I want to take the risk of enrolling in a second trial or, doing other interventions? It's really challenging. I would encourage all of you to, pursue prenatal screening for the rest of your families and recognize that it is related to research, and really advocate for the newborn screening in states that don't have it. If you're in a trial, you want to make sure that you can continue the therapy if it's effective after the trial, that will be allowed. There's a lot to learn from the previous trials, and I think what's going to be more challenging as a community, and we look forward to this, or look at this going forward, is that there are only so many people with SMA, which is a good thing, but as a result, the more people that are on therapies, the more complicated the trials become, and the less people there are available, and the harder it is to determine, does one drug work in conjunction with another, or is it better than another one of the other available trials? And so it may take longer to get to that next step. I mean, we're all looking for the cure, but it may be even longer now as we've got people, and rightfully so, getting treatments. So it's something that we're grappling with as a community, and something to consider as an individual. And then reflecting back on what Mary talked about in terms of optimizing care, clinical interventions and decision making are essential. That none of these treatments, the Risdiplam, Zolgensma, Spinraza, are going to be optimal without optimal clinical care. We want to make sure your respiratory health, your bone health, your GI and nutrition, all of that is optimized. And so, stay engaged, and it doesn't necessarily have to be research related, but stay engaged with your team. We help you get to where you want to be. Next slide. So what are your options? You have to make choices that are consistent with your personal beliefs. As you said, every family that's part of Cure SMA is coming from their own personal experience. They have their own beliefs, their own values, and you have to work within your own family and access your resources to say what's best for you. And then, really the hope and prospect of the research or the current drug therapy, should be in parallel with your clinical supports. And so work with your pediatricians, work with your neurologists and your pulmonologists. And it may be not that you need to see me, which would be the ideal, but I can maybe help you, identify what are things you should watch for, or how do you anticipate these types of things. My goal is that I wouldn't have to see you in the ICU, and I wouldn't have to help you with cough assist and BiPAP and those types of things, but I might be there to help answer questions where there's uncertainty. Next slide. So chutes and ladders, for those who remember when it looked like this, SMA, we're not at 100%. We haven't reached that goal. We are so much closer than we ever used to be. And our hope is that there aren't so many chutes anymore. But we want to help you try and navigate this. And so this is one of the objectives of the entire sort of conference that you're participating in, but also Cure SMA's mission all along. And so really reach back to us and really stay engaged in the community. It's sort of essential. Next slide. And so I'm hoping I've been able to help introduce some ideas about sort of the ethical and pragmatic and emotional issues related to treatment and research, and give you a sense as to how we think about it and how you might want to think about it. And really, again, please stay engaged. And we really appreciate any feedback, and look forward to working with you and hopefully seeing you going forward. Thank you. Next slide.
Hi, thank you everybody, and thank you again, Rob and Mary, for sharing today and providing this valuable information on treatments, trials, and care. We appreciate everyone who's joined in, and you will see a survey link in the agenda page, and we would welcome any feedback that you have to share. You'll also be receiving a survey link in an email as well, so you can always take it a little bit later. And once again, we are incredibly thankful for the support from our sponsors for making the 2021 virtual SMA conference possible. And don't forget to join us this evening for the Newly Diagnosed Mingle at 5 o'clock Central Time to connect and socialize with other recently diagnosed families. If there's anything that we can do for you, or if you have any additional questions, please email us at familysupport@curesma.org. Have a great day, everyone, and thank you again for joining us for the 2021 Virtual SMA Conference.